asked me to give a talk on the rheumatoid hand, the Indian scenario. I said, I rarely operate on the rheumatoid hand. He said, why? I said, I don't get the patient. If I get the patient, they don't agree for the surgery. So he said, don't worry, you come as a tail ender batsman. And tail ender batsman doesn't score much high. So with this, I will start. With the newer generation of the good drugs, including biologics, the incidence of surgery has gone down significantly. When I was doing the training in label, around 10-15%, sometimes 20% list of the surgical list were about a rheumatoid hand deformity correction. But since last year, there is a great deal of new drugs are coming out. So the incidence of going into the joint deformities, synovitis has gone down significantly. Our aim should be to reduce the synovitis either by medical synovectomy, that is by drug, disease modifying agents, biologics, or whatever the way, non-invasive way you can do it, or locally reduce the synovitis by local steroid injection. And if we fail, then by surgical synovectomy, and then whatever is the things required. Why the synovium is, this synovium contains lots and lots of macrophage. They are eating the cartilage, they are eating the tendon sheath, they are eating the things like anything. So in our Indian scenario, deformity is not the indication of surgery. If they are able to do the activity of daily living, they are not ready for the surgery. Whatever is the reason, they are very happy. This lady who came to me for this deformity, if I say, if I ask her for any deformity correction, she said, I'm completely fine. So I said, why do you want to see me then? Said, to prevent any deformity, or what else without surgery you can do it. I am able to do each and every activity of daily living. She has a bilateral hand involvement. So I'm a letter is in anti-deforming force on both the hand, and she is using since about 1.5 years. And for the night time, the right hand deformity stop progressing towards the worst. The left hand deformity is maintained to the same, and she is very happy. She said, my pain has gone down, but despite deformity, there is no pain, and nobody wants to have a surgery. Even if it is my hand, I would probably go in that way only. So why they seek the consultation of a hand surgeon? When there is no pain, right? Like this lady, when there is no pain, why she has came to me? She want to get the answer. Can anything prevent the deformity? If yes, is there any non-operative way? Or should they need you? What a warning situation when you should meet the surgeon for the surgery? That's for this question that lady who is having a rheumatoid arthritis on drugs since last around 15 to 20 years came to meet me. Otherwise, no reason, nothing they want to get correction. They are will to do functionally. From the outset, patient should be explained that doing one surgical procedure does not mean that they will not require any future surgical procedure in the same hand, or for the same problem or a different problem, because you are treating a systemic problem by offering local treatment. Rheumatoid is an autoimmune disease. It affects every tissue of the body. You are just looking at the X-ray, is a bone. What about the cartilage? What about the collateral ligaments? What about the tendon sheath? What about the capsule? Everything is being eaten away by the macrophages of the synovium. So five surgery comes into the category of the rheumatoid hand surgery. One is synovectomy of the joint, tenosynovectomy of the tendon sheath, tendon surgery, orthoplasty, and orthodesis. As far as orthoplasty is concerned, I don't have any personal experience of doing any orthoplastic procedure in the hand, except for the excisional orthoplasty, no implant orthoplasty. I don't think they are available also. One must be able to match the patient expectation with the surgeon's goal, and it should be very clear from the day one. Like I have seen few patients who has been operated for the tendon repair, tendon rupture surgery of the one finger, and after few months they had another tendon rupture. The patient was not been explained from the beginning that this may happen in the future. This is a doctor who has a rheumatoid arthritis, who has a spontaneous rupture of the ring and small finger extensor tendon. The treatment was very simple. Do a side-to-side tendon transfer and use the one, sometime middle finger as a two slip of the EDC. So one of the slip can be used and transfer. This is a satisfactory follow-up after a 6-month period of time. She is continued to do well. Additionally, some procedure was also done for this on the undoing the DRUJ synovectomy with some interposition. One of the most common surgery we see in the rheumatoid is a lady with a chronic synovitis and a severe carpal tunnel syndrome. She is on the disease modifying agent and she failed to respond to the conservative line of treatment. Carpal tunnel release with the synovectomy was done to give a relief to the symptoms. A rare case, you can have a monoarticular synovitis. The patient came with a chronic wrist pain with the swelling and had a trial of antitubercular treatment for 6 months with no relief. We went for the diagnostic biopsy and the biopsy proved out to be rheumatoid, and the treatment for the rheumatoid resulted into substantial relief of the symptoms. One of the common situation, people reach to us quite late when the disc joint is completely destroyed. She's a villager, poor lady, is a complete destroy of the wrist joint, DRUJ is all gone. She with the pain and there is a lot of synovitis over there. So what we did was, we did the synovectomy, we completely took out the synovium, we fused the wrist in the as best as possible, this direct procedure little bit over here and put a multiple stem and pin, and they have a nice stable wrist with a complete relief of the pain. Lot of the rheumatoid wrist patient who have a complete destruction of the joint with the pain, if you just do the in situ position, in situ pinning, when they don't have the synovitis, the joint get fused automatically. This is again a doctor who have a spontaneous rupture of the sagittal band. He has in the middle finger. He is also on the disease modifying agent. You see that it's not getting it. Disease tender over here and it happens spontaneously. That can be treated. That can be treated conservatively. You made a custom-made splint with the thermoplastic, keeping the MP joint in extension for about 6 to 8 weeks. Remember, rheumatoid is an autoimmune disorder. It is a systemic disorder with a slow healing process. So instead of keeping the left hand, probably 6 to 8 week period is required for this tissue to heal. And once the adequate time of splintage is given, you can see this near normal recovery of the finger extension and the flexion. You need a cooperative patient to get the things done properly. Another lady, 30-year-old, who came with the chronic dislocation of the thumb MP joint. It was about 4-month duration, and then she was having a lot of problem with the drug issues, complication with the drug issues, so surgery was contraindicated initially. Once she got settle of everything, then we went inside, and obviously the joint cartilage completely destroyed, and did the fusion of the thumb MP joint, and she had a very good painless functional thumb. And so these are the common surgery. If you talk about what are the most common surgery I do in the rheumatoid hand, carpal tunnel, yes, very common. Trigger finger, yes, very common. The next common surgery is a tendon rupture. Joint dislocation of the finger, yes, especially people go for the thumb surgery correction, but I have not seen anybody is going for the MP joint correction. Whenever I advise, they are all happy with that, whatever. If there is no pain, nobody is willing for any surgery. The wrist fusion, yes, it is, and synovectomies. Thank you very much for patiently listening.